So next speaker we have is Anke-Hilse. So Anke's recorded her presentation, which we'll show in a second. Unfortunately, she can't be here to join us for the live Q&A, but please do still submit questions in the Q&A function. We'll be able to send those to Anke-Hilse as well to get responses from her, which we'll share along with the video when it's all made available. So she was trained as a pharmacist, clinical pharmacologist, and epidemiologist. In 2016, she was appointed full professor in the Amsterdam UMC, precision medicine and respiratory disease. She's published more than 300 peer-reviewed articles.
Hello, this is Anke-Hilse Maitland-Van, and I would first like to start with thanking Allstone for inviting me to give a presentation on the use of longitudinal breath measurements at home in chronic respiratory patients. Is this the future or fiction? So starting off, I have to say that I did receive some grants from several pharmaceutical and other companies, and that I've also served in several advisory boards, but I don't think any of this will influence the content of my presentation today. So why would we be interested in longitudinal breath measurements? Well, I think by now we all know that it's possible to measure things in breath that can tell you something about the diagnosis or about the disease state of a patient. But if we do this cross-sectionally, it's interesting, but it can be influenced by a lot of other environmental components. But if we measure a patient over time and compare the patient with itself, that might help us to, for example, detect exacerbations in patients with chronic respiratory diseases, viral infections or bacterial infections. And these can help us to optimize treatment for patients with chronic diseases, quicker treat, and maybe diminish the amount of lung damage. So let's see what we have already found and whether we can bring this to the future. So first of all, I think I don't have to tell this audience, but what we can measure from exhaled breath are different compounds that can either come from the lung, but also can come from the general circulation of a patient. It can have to do with bacterial processes that are going on in the lung, and we measure the metabolites, but it can also be local cellular mechanisms or, like I said, things that come out of the circulation. So a lot of different things can be measured in exhaled breath. And we can do that in two different ways, or we can do it in even more ways, but I think the two main ways to detect the VOCs that are there in exhaled breath are either based on a chemical analytical process, such as, for example, a gas chromatography mass spectrometer, or on a pattern-based way, where we, for example, use an electronic nose. And I think both these steps can be used if we want to move towards longitudinal measurements. The advantage of the chemical analytical based methods is that we know exactly what we measure, and that if we know which compounds can be important to detect, for example, certain bacteria, then we can look exactly for the VOC that's of interest to us. But using these sort of methods is quite labor intensive, because we cannot do this at the bedside of the patient, we have to bring it to a lab. So that's the big advantage of the electronic noses. So if we know what we want to measure and we know which sensor is very good in measuring that, then we might be able to bring the analysis method to the home of the patient and have a very quick and easy measurement with a direct result. So like I already said a bit in the introduction, there's different moments in the patient's journey where we can use breathomics. So we might be able to predict disease, make a diagnosis of disease. We can see the difference between patients with and without asthma, for example. And then something very important, if we can predict an exacerbation, if we can see which patient is going to have an exacerbation, then that might help us to actually change or add therapy and prevent this exacerbation from happening, and thereby making sure that the patient will have a longer time in better quality of life. So the first results I will show you are from the Spironose. The Spironose is electronic nose that is now marketed by a company called Breathomics, and that was earlier developed at the Breathomics group of the Amsterdam UMC. As you can see, the little girl is blowing into the device, and the device has 8 sensors in an inner circle, and the same sensors also in the outer circle. As you can see here, this is where we look into this part of the eNose. And so the sensors are not only here to analyze the patient's breath, but they're also here to correct for the components that are there in the ambient air. So with this Spironose, we made a collection of data from different groups of patients with lung cancer, the purple ones, patients with asthma, the green ones, with COPD, and also a group of healthy controls. And the two analyses that I'll show you now were performed in this population. So Joep van Bracht, a PhD student in my group, showed in his paper in Metabolites in 2021 that we were able to make a distinction between patients that had an exacerbation in the past 3 months and patients that did not have an exacerbation in the past 3 months. So of course, this is not a prospective study, this is a retrospective study, but it seems that there's something different in the breath of patients that had an exacerbation. So maybe we can smell an exacerbation. And this was true in all asthma patients in our cohort, both in the training and in the validation set. And this was also true if we did not include the antibiotic users in our cohort. We still had the same areas under the curve. And it was also true if we excluded the current smokers and if we only included patients who used maintenance inhaled corticosteroids. So in all these groups, we could show a difference between patients that did and did not have an exacerbation. And actually, Job showed the same thing in the group of COPD patients within our cohort. Also there, within a training and in a validation set, we were able to show that patients that did have an exacerbation in the past 3 months were different from patients that did not have an exacerbation. And why this is important here is because if it is true that we can smell an exacerbation, we might be able to smell this also before the exacerbation starts. And of course, we'll still have to see this, but this is a first sign that it might be useful to monitor these patients more longitudinally. So another study that we performed, this was done by Marije Lammers, who also graduated in my group, was a study with the rhinovirus challenge. Here we included a small population of 12 healthy people and 12 asthmatics. We actually challenged these patients with a rhinovirus. And then with the eNose technology, we kept measuring them longitudinally 2 or 3 times per week for a total period of 90 days. And then we looked at the fluctuation of these measurements over time. And in the next page, I can show you the results. So here you can see when these measurements were done. The blue period is pre-challenge. At the end of the blue period, they got a rhinovirus challenge, and then the orange measurements were in the post-challenge. So here you can see a couple of different sensors from the Spironose. And if we look at the healthy people, we can see that all the measurements, for some sensors in the orange period were different from the measurements in the blue period, which was pre-challenge. Only for sensor 6, there was no difference. But looking in the asthmatic patients, we see a similar thing, but only stronger. So here, for all the 4 sensors that are shown, we can see a difference between before and after the rhinovirus challenge. And an interesting extra thing to tell here is that these patients did not only have a different picture once they were inoculated with the virus, but also that we could smell this difference even before the patient started to show symptoms. So this is actually very important because this might mean if we measure patients over time that we are able to identify a viral infection and so maybe the start of an exacerbation before the patient even notices. So the last example I would like to give you is that we also might be able to detect bacterial pathogens within a patient's lungs. So if we want to do that now, and this is especially important in CF patients, it's actually a very time-consuming process where we have to take a sample, do a culture, and then wait until we can detect which pathogen is there. So therefore, this is really the moment to improve this process. And we therefore decided to see whether it would be possible to detect these pathogens with the use of exhaled breath. And for this study, we actually decided to make use of a GCMS to actually find the compound that would be responsible for making the difference. And because there's lots of compounds and the amount of CF patients with samples was rather low, we decided that we would work with a group of candidate VOCs. Therefore, we performed a literature search to detect compounds of interest that were associated with the bacteria Pseudomonas aeruginosa that we were interested in. So with the compounds that we found, we looked at the axial breadth of the patients that we collected with a disposable setup on a carrier. We looked whether we could find the compounds in the GCMS and compared that with the status of their cultures. So we called this a hypothesis-driven approach because we only looked at those VOCs that were already found associated with this particular bacteria. And that way we would have more power to find actually those VOCs that are significantly associated. So the study that we're talking about included in the end 39 articles, and 29 of them were actually based on in vitro research, 7 on in vivo, and 4 on ex vivo research. So these were the studies where we found the compounds that we tested, and then we also had a patient population available that included in total 53 patients. There were 2 patients that had no GCMS data, and then of our 51 patients that were left, 13 had a chronic Pseudomonas infection, and there were 28 who had no Pseudomonas culture in more than 12 months. So in total, we had 16 Pseudomonas positive patients and 28 Pseudomonas free patients. And this was also still divided over adults. We had more adults in the positive population, and we had more children in our negative population. So in these articles that I just showed you, we found 241 VOCs, and 56 of these VOCs were also discovered within our patient cohort. So we were able to identify one single VOC for children and a VOC fingerprint for adults that was able to discriminate between patients with and without Pseudomonas aeruginosa. So for children, ethyl acetate turned out to be a very good predictor of whether a child had Pseudomonas or not, with an area under the curve of 0.87. In adults, this predictive capacity of ethyl acetate was a lot lower, 0.67, but if we added several other VOCs to it, then we were able to obtain an area under the curve of 0.86 to see whether a patient had Pseudomonas or not. So this means that maybe we can move away from the time-consuming and also quite difficult methods of measuring Pseudomonas in patients with CF, and we can actually go to the much easier method of obtaining some breath and see whether the patient has a Pseudomonas infection. And this we can measure over time at a patient's home, and therefore be really quick in noticing when a patient has a bacteria and maybe should be treated for it. So especially this last example shows you that we think that eNOS and GCMS studies should be combined, because if we are able to identify candidate VOCs by the use of a GCMS method, and if we then understand also the biology between these candidate VOCs, then we are able to develop specific samples or find specific samples that respond very well to these candidates and then implement this in a population. And of course, this is an ongoing process, but we think combining the two methods will give us a good idea about what we're measuring using the GCMS, but will also help us with the advantages of using an eNOS in the much quicker and procedure to use an eNOS and get a direct answer that we can also use at the patient's home. So here you can see our very, very first prototype of the pheasant. And the pheasant is supposed to be a small device that we can bring to the patient's home, and where the patients can actually use easily once a day, once a week, depending on I think the severity of their disease and what we're trying to measure. As you can see, it's also possible to exchange the sensors that are in the pheasant. So this means that we can make a specific pheasant, for example, patients with COPD or for patients with CF. If we think back of the example of Pseudomonas, a pediatric patient with CF, it might be very much useful to have a sensor that's very good at detecting ethyl acetate. However, for an adult patient with COPD, this might be much less useful. So we think that we can make an optimized pheasant for every patient and that this can then be brought to their home. Chronic respiratory disease patients might benefit from longitudinal eNOS measurements because we might be able to detect exacerbations even before the patient notices. This might be a reason to change their therapy, and this might help to possibly prevent the exacerbation. The choice of sensors is very important, and these might differ per disease. And I think lots of GCMS research is necessary to find the important VOCs and then to learn which sensors we can use to detect them. And also, devices nowadays that are used for measurements of exhaled breaths are quite expensive and can only be in a hospital. We think that it's necessary to develop something that's simple and non-expensive so that we can measure patients longitudinally and get more information and quicker information from the patients that can help in really changing their quality of life. So with this, I would really like to thank you for your attention. And of course, I would like to thank all the people in my group from Precision Medicine and Respiratory Disease group from the Amsterdam UMC. So I hope that I've made you think about this. And of course, I'm very happy to answer any questions. Thank you very much.